Good evening. We are almost there. Yeah? Thank you for those who are still hanging around. We really appreciate your time here. Today, we are in Symposium 18, and we have a very renowned expert who's going to talk to us about addiction and dependence in older person. Dr. Parameswaran Ramasamy is a consultant psychiatrist and addiction medicine specialist. He has a long list of expertise. He's the head of addiction services in Seremban General Hospital and a visiting addiction specialist at Hospital Kuala Pilar. He graduated with MBBS degree. He has a master's in psychology medicine, and he did a fellowship in addiction medicine as well. On top of it, even in 2009, he had another fellowship in addiction psychiatry. He has worked in General Hospital quite extensively in Malaysia and also at the Psychiatry Institute as well, with the Malaya Medical Center, St. Vincent Hospital, Liverpool Hospital in Sydney, and also Prince Alfred Hospital, who does excellent work in substance abuse, mind you, within the community. So he certainly has a lot of experience that he will be sharing with us today. Currently, he is also a state psychiatrist of Negeri Sembilan, and also has mentioned he is working as a consultant psychiatrist at the Department of Psychiatry and Mental Health at Tengku Jafar Hospital, Seremban. He is also an honorary senior lecturer, trainer, examiner for undergraduate and also postgraduate students. Without further ado, we would like to welcome Dr. Parameswaran for his talk this evening. Thank you, sir.
Thank you very much for the kind introduction. A very good evening. I think everyone is tired. My slides, I have only 15 slides. It's short slides, but a lot of information. I hope that helps you in your day-to-day practice, as well as if you have any patients with dependence, especially in elderly, you can help them to deal with their dependency issue. Just a background, so this is the outline. So basically we look into different areas, what are the risk factors, what are the prevalence, what are the predictors, and so forth. To start with, a bit of facts and myths of substance use among older adults. Okay, there's always this notion that people older, they are not at risk, and they think that because they never become a dependent, so the chances of them to become dependent at an older age is negligent. But actually it's negligible. So it's not true. Addiction is continuum. It can occur anytime at your age, and some people, they think that as you go older you have more control over yourself. But we do see newer cases, the person who doesn't have a background of drug use before, and then at an older age, maybe about 50, 60, or even 70 years old, they become dependent. And mostly it's benzodiazepine and also pain, opiates. Unfortunately, a lot of people have this thing that, older people, we do not ask this question that, they are at risk or they are dependent on the drugs. So it becomes a hidden illness whereby they suffer silently. So therefore, asking certain questions regarding drug use or drug abuse would be good. But it will be very difficult to ask them because you can't ask a direct question. It will be always an indirect question. Later on, we'll be touching something on it. So overall, managing dependence among elderlies is a complex and it's very challenging. All right. So a bit of prevalence, we do not have any local prevalence regarding the drug use among elderlies. But if you take US statistics, it shows that elderly people at risk, about 3% of them are at risk in general population. But if you have a hospital setting, it can go up even up to 20% or 22%. Smoking, now with the vape and all that, perhaps maybe the smoking issue is still there, but sometimes maybe they're smoking lesser Even in Malaysia, you can see elderly people still smoking. Illicit substance use, these are things which, you're talking about heroin, you're talking about amphetamine and so forth. Most of them, if you ask a general history, there'll be about 20% of them will have some lifetime use of drugs. They're not dependent on it, okay? But some of them fulfill the criteria of illicit drug use. This illicit drug use, when you see that, substance use, about 11% of elderlies are using illicit stuff, these are prescription drugs. These are like, benzodiazepine, which is bought at the counter, or they use someone else, diversion, taking from someone else. So these are substance use, including pain drugs, like tramadol and so forth. Prescription drug use is a bigger problem in US. It has hit up to 30% of general population, especially in elderly, because the abuse is very high and the support system is not there. Benzodiazepine occupies 1/3 of the basic abuse of drugs. In Malaysia, the only statistics I could find was from the Home Affairs Ministry. People with 50 and above, they are at risk of dependence. They have been arrested for either amphetamine, cannabis, and opiates, so forth. It's average about 2,000 per year. So every year, there's 2,000 people been arrested for that. But in our day-to-day practice, we do see alcohol is one of the most commonest thing. Ketum is there, tobacco is there. Benzodiazepine and painkillers are very common. So these are things which we see day-to-day in our clinical practice. For example, I have an elderly gentleman who is tramadol dependent, and he does doctor shopping. He will have the whole session, end of the session, and say, "Doctor, can you just give me a few tablets of tramadol? I have this body ache." And that is this standard way of getting drugs from all the doctors. Similarly, benzodiazepine, same thing. They'll go and approach the doctor, say that I have sleep problem. Just give me about 10 or 15 tablets. I'll take occasionally. I do not take every day. And he does the same thing with the other doctors to obtain benzodiazepine. So these are some of the clinical practices you will see in your day-to-day practice. The Clinical Geriatric Medicine 2014 has given a risk factors related to substance use in the late life. So these are the risk factors. If you assess a person and then you want to look into what are the risk factors, whether it's a possibility of dependence or abusing. So this will be a good factors. There are 3. So physical, psychiatry, and social. In physical, male predominantly is alcohol. Female is basically more of prescription drugs, benzodiazepine and so forth. Caucasian, chronic pain, person who has a chronic pain, physical disabilities, transit transit in care or living situations where they do not have other supports, so family supports are not there. Poor health status, chronic physical pain, physical illness, or polymorbidity, or polypharmacy, where they need to take multiple drugs. So this is where the chances of them risk of them to self-medicate or self-treat, or once they are dependent, they go into a vicious cycle. Psychiatric factors, risk factors, avoidance, coping issues. Some of them, they have issues with coping. Especially at present in my day-to-day practice, I do see a lot of people, elderly people, after the COVID, the fear of COVID and things like that, they find it difficult to cope. So similarly, sometimes the change in the living situation, children are away and things like that, they find it difficult to cope. History of alcohol problems or previous history of substance use, and also if you're underlying mental illness or any psychiatric illness, it puts them at a higher risk. Social risk factors, these are affluent, people who are rich, well off, because they can go to a doctor and say that, no, give me a month script of benzodiazepine, and they keep on using these drugs over a long period of time. I have people who are benzodiazepine dependent prescribed by doctors 10 years, 15 years, 20 years, and they will finally they'll refer as benzo dependent because when they want to stop, they find it difficult to stop, or it is interfering with their cognition and all that, then they refer, and we find it very difficult to deal with this kind of patients because he's been on it for a very long time. When they lose their spouse, any bereavement, family members, and this puts them into a higher risk of using this kind of drugs. Unaccepted and forced retirement. So sometimes it's not a planned retirement, so they might just retire. After that, they have nothing much to do. There's no social life and things like that. So the loneliness and all that, and most of them go to alcohol and so forth. Social isolation, living alone or with no spouse, so this also puts them at risk. So these are, when you get your patients or your clients, you can ask this kind of risk factors to identify whether they are at risk. Second issues we have with this is diagnostic. Yes, we use DSM-5 to diagnose substance use disorder, but you can use ICD-10, there's nothing wrong. Why I use substance use DSM-5 here is easy to explain. There's 11 criteria, but the problem with the elderly, they have their own limitations. For example, let's say if you want to ask about the drug history and all that, they may have cognitive impairment. If you're going to ask them, uncle, can you tell me past 1 year, how was the frequency? He can't give you an accurate picture. He'll give you an approximate. Not much, very less. And then you'll be asking the same question again and again. It'll take about 5 minutes before getting the answer. You get the answer and then you ask the family, the answer is totally different. The family will say, no, he's drinking every day. So that kind of thing. So you need collaborative history to confirm. So just don't go by the criteria. Sometimes you have problem because persistent desire of using drugs. Here they're using prescription drugs. They are not using maybe illegal substance like amphetamine and all that. So you might not see major symptoms. So they say, no, I take only for sleep. I take whenever I have pain. So you might not see the actual symptoms. So therefore, we need to explore further. Craving is the same like general population. There's recurrent substance use. This may be lesser in older adults because sometimes what happens is their consumption is not so much. So therefore, they might just take 1 month script and then it may last about 3 weeks or 4 weeks. So therefore, they may not frequent to the doctors, but that medication which they have, they are taking extra. So the effect of the drug is more as compared to when a younger person takes. So continuous substance use, they may not realize. Sometimes what happens is when you prescribe medication to be taken, maximum of, we do not always mention in our clinical practice maximum. We will say that every day 1 tablet. He said that no, I can't sleep, so I took another tablet. And then subsequently it goes on that basis. So sometimes he take extra tablets. The other thing is regarding is he might not engage with the older people. They might not get a lot of. They do not engage with social activities, or they do not go out much. So therefore, when you ask the question of impairment of social activities, you might not get a detailed history, because he said that I don't go out, I stay most of the time in the house. So one of the questions in DSM-5 regarding substance use is whether it impairs your social functioning or interpersonal relationship functioning. So lastly, the tolerance and withdrawal. This varies quite a lot with elderly because the liver is not functioning as what it used to work. So even at a average or normal dose, let's say if you're prescribing 1 milligram of lorazepam, it would be quite high for them. So they say that, no, I haven't changed the drugs over a period of time. But then when you're younger, when you take 1 milligram as compared to when you're 70 years old, you're taking 1 milligram, the effect is more. So it may be a part of tolerance or part of sensitivity. So it can affect the cognition, it can affect their functioning. Similarly, withdrawal, because of the physically they are not strong, so sometimes you do not see really a physical withdrawal. So maybe they may have some psychological withdrawal too, but it will be more like symptomology. I have headache, my body is not feeling good, and I feel tired or whatever. So it will be something of very subtle kind of psychosomatization. For the use of substance use in older adults, they categorize into 4 groups. Basically, is you see a patient and say that whether it's abstinent, then you don't have to do any intervention. If it's a low risk, say occasional drinker, or occasionally uses certain drugs, then maybe you need to advise them, psychoeducate them. And then high risk, yes, this one needs some intervention. So the intervention part we will explain later. But it is not easy because they do not come to hospital. Normally they'll come like 6 months supply or 4 months supply of medication. So whatever you do, there's no follow-up. So sometimes you need to have a better team to support them. If it's a problem user, especially when they already have some underlying medical problem or psychological consequences of the drug use. So they may need intensive treatment, and some of them may need to be admitted in the ward to do the treatment, especially like detox or medical stabilization. This is another interesting chart. I know that the content is a lot, but it is helpful, so you don't have to go through each and everything. But the main thing is, these are indicators. You know, when the patient comes to you, yes, earlier I mentioned about high risk. This is an indicator to say that, you know, whether this person is using the drugs and is he affecting his life, or does he have any signs or symptoms. So this is more like a sign. So you have a physical sign, you have a cognitive sign, psychiatric and social. So if you look at physical sign, you know, he has multiple falls, falling down, having some physical symptom like headache. All this will be the indicator for you to say that, you know, maybe is he taking extra tablets or is he abusing certain drugs? So therefore your questioning should be based on that. Sometimes that's why when they come to the symptomology, we do not ask question, we keep on prescribing symptomatic medication, which would not be good. Because I have patients who say that, you know, oh, I can't sleep, I go and see my GP and get some cough syrup, so I take cough syrup, I can sleep. So this kind of thing. So sometimes they go there, oh, doctor, I have a cough, can you give me a bottle of cough syrup? So these are the normal things they do in your clinical practice, so you have to be a bit careful. Cognitive symptoms, okay, so these are the memory, when you assess the patient, if you have some memory problems and things like that, there is drug-drug interaction, or maybe if he takes extra, so maybe he becomes confused and things like that. So therefore, evaluation has to be done properly about this cognitive assessment, as well as history from the family. If they noticed him, suddenly have some cognitive impairment and things like that, so most probably he has used some drugs at that same time. For example, my patient I told you regarding the tramadol abuse, he takes tramadol 50 milligram TDS. Whenever he hits to 200 milligram, so that means 50 milligrams, sometimes take 100 milligram TDS, he'll have fainting spells. And every time he'll go to the hospital and the doctors will say that he had a seizure, they'll do the investigation and everything, but he will never open his mouth that he has a tramal issue. And in tramal overdose, he had a seizure. So it will be interesting to ask this kind of question. Psychiatric symptoms, sometimes sleep is the most commonest problem, so they would take the medication. So sometimes what happens is they take the medication, at 1, 2 o'clock, they still can't sleep, they'll take again. But when you ask them, they'll say that, no, I don't take, I just take once only, I take half a tablet only. But in reality, it's different. And this one, you can ask the family, and the families will say, oh, no, doctor, if I want to take his medication, supervise his medication, he will scold me. He won't allow us to touch the medicine because he wants to adjust the medicine. So these are things you need to talk to the patient, that you can't hold the medication, you have to allow the family to hold the medication, things like that. So underlying anxiety, depression, which sometimes they do not voice out. So because of the anxiety and depression they're having, so they use benzodiazepines or they use whatever medication they get to self-medicate. So sometimes looking or verifying this kind of information is very useful. Social is very important, because a lot of people have some social problems. So whenever they come to you as elderly patients, so if you do not ask about the other things, other aspect of his house life, how you're getting along, how you're managing yourself, how's your family and things like that. So if you just ask about symptoms, okay, you have hypertension, diabetic, you have this problem, so you just prescribe medication, you might miss out the most important things. So this is where you will look at, you know, normally I will ask how are things and all, how you're coping, how you're handling yourself at home. So if you have any problems, does anyone talk to you? So that kind of conversation I will have. And normally I'll ask, do you attend any function? Did you attend any function lately? So things like that will be helpful. So look into potential indicators of substance misuse and abuse. This is it is available in online. It is the Canadian Center of Substance Abuse Care Pathway. It is a 4-page, so I've broken down into a simple format. So, but the full format you can download from the internet. So basically, this is regarding management of them. So basically, general screening. So whenever you get a patient, it's good to do a general screening. But this general screening is a continuum from the primary care, psychiatrists, psychologists, geriatricians, anesthesiologists, the whole works. So it is not something as an individual. No one can manage elderly people individually, so you need this whole team. Most importantly is knowledge. So creating helping the health professional to have knowledge about these are the issues they are facing and things like that, it helps a lot. Screening tests you can do, especially when they come, like the primary care, they do the test. So adding on another test, like asking about his drug use and things like that will be useful. So the best I would advise is the last one is called as ASSIS. There's alcohol, smoking, substance involvement screening test is ASSIS. It covers all except for alcohol. The alcohol one is not sensitive, but you can use it for normal screening of any patients, whether they are at risk or not. All right. Second thing is, once you do the screening, next is a specific issues. Some already have benzodiazepine issues or opioid related issues. So if you have opioid or benzodiazepine issues, that becomes straightforward. So you can look at various other things, like, the withdrawals and things like that. You can ask a direct question. So sometimes, as I mentioned earlier, because of the sensitiveness of the benzodiazepines, so previously when you're younger, it may be 1 milligram, now they're still taking 1 milligram. So it is considered higher for them, but still they'll say, I'm comfortable with it. So we need to explain to them about this benzodiazepine, and we'll try to identify whether it's really dependent or not. Similarly to the opiate use also. So once we identify that, then we will look into whether it's ready to change. It's called as, it's based on motivational interviewing techniques. So we will look at whether it's ready to change. Is it important for him to change? Is it confident enough to change? So there's called stages of change by Prosca and De Clemente. It's a pre-contemplation, contemplation, preparation, action, and maintenance phase. So we'll look at where they are. Based on that, we'll do the intervention like psychoeducation or supportive therapy or psychological interventions like a brief intervention and so forth. And then once we identify that, so we have to make a diagnosis. Once we have diagnosis, then we do the craving dependence follow-up in the regular routine follow-ups. So all this step care assessment, it is not something, because not everyone is at the same risk. So we evaluate and then we see that it's readiness or change, then we do the intervention. There are, as far as treatment is concerned, there are 4 major treatments. That's the green one. Brief intervention, withdrawal management, medication-assisted therapy, and psychosocial intervention, which I will describe a bit detail the next slide. So these are the intervention they do as a treatment approach. Subsequent to that, this is ongoing. The recovery, relapse prevention is like coping, how to cope with without drugs and things like that. So we will continue that. And also we will look at any triggers, high-risk behaviors and things like that. Skill training for coping is very important, because now they're physically disabled, or maybe they have physical problem as well as they are suffering from pain, or they are suffering from emotional problem. So maybe we need to do a multidisciplinary approach, which will be very useful. All right. So it is basically I took it from the the intervention, the flow chart. So, but don't have to go through the whole thing. It's just to describe. It's easier to understand if you have it there. So, brief intervention. There are different ways of doing brief intervention. So, like WHO does the brief intervention based on stages of change, and they do frame. Frame is intervention method. But what they recommend here is they recommend motivation interviewing and CBT. CBT is basically more of cognitive behavioral therapy. It's based on relapse prevention. So this is useful for especially like psychoeducating a person with a benzodiazepine. So there's an example of how to do psychoeducation for benzodiazepine dependent. So normally what we do is, like, we have a benzodiazepine dependent, we will explain to him, we have to start all over again. We can't into it, because he will say that he has sleep problem, that's why he's taking the medication. He will never admit that he is dependent. So we have to settle his benzodiazepine dependent, the sleep problem. Or he may have anxiety or depression. It's a secondary due to long-term use of benzodiazepine, so we have to settle that. Then we will discuss with him about the benzodiazepine. So normally what I will suggest is, okay, long-term use will impair your cognition, it will affect your sleep, the circadian rhythm will be affected, and we will suggest for gradually tapering down the medication. So it will take at least 2 or 3 sessions before even he agrees. Sometimes he will say that, no doctor, you do whatever you want, but please do not stop this medication. So sometimes it takes months just to get him ready. So it is time consuming. So you don't have to rush, because as long as someone can monitor him, assure him he doesn't fall, safe to take, then it's fine. Withdrawal management. So withdrawal management is basically like you're doing a medical stabilization or a detox. But with the elderly, it's a bit more complex, because the liver is impaired. On their physical side, is they are also having disabilities. They are on multiple medication. There's drug-drug interaction. So it's a bit more complex. But we use lower dose of any medication, or maybe with a precaution, and we'll make sure that we monitor all the parameters, and then we will slowly readjust. For opioid dependent, we can still use methadone or buprenorphine as a detox part of the regime. For benzodiazepine, this is a bit tricky, because you can use long-acting benzodiazepine, but the long-acting, there's a risk of accumulative effect. So therefore, sometimes we still use short-acting, but we will suggest for gradual tapering down. So if you have some multiple medical comorbidities, sometimes we go real slow. So it'll take maybe about, instead of normal, if I do a normal benzodiazepine withdrawal regime or detox for a young adult, I will do it maybe in maximum is like 2 weeks, and then I'll stop the medication, or maybe maximum I'll go for 1 month. But for elderly, it will take about 3 months to 6 months, because you can't go fast. The moment you go fast, he will say that, I have a lot of problem, my sleep problem is affecting me, I cannot function, and so forth. And then the medical assisted treatment. Okay, so we do put them on some maintenance therapy, because this person has been taking benzodiazepine for long term. So if you want to stop abruptly, it's very difficult. So we do put him on, but suggest that, no doctor shopping, family should supervise the medication and things like that. And then we will try to improve his sleep hygiene, how to improve his physical activities, or add on some other cognitive activities for them to get a better sleep. At the same time, the medication will be added on. We'll find the most safest medication, or the one which is suitable for him, and then over a period of time we might. So I have patients who are maintenance like 1 year, 2 years. It's so difficult to cut down. But as long as each time they come, you advise them, you tell them that, these are the risk factors, these are the problems with the drugs. So over a period of time, they have the acceptance. So they will come and tell you, doctor, so I never increase, I never take even 1 tablet extra already. I'm just taking exactly your order. So that kind of thing. So it will be something which is good. The psychosocial treatment, yes, this intervention is needed. SAMHSA has introduced a protocol how to do. Their focus is basically they're focusing on supportive therapy, cognitive behavioral approach, development of a skill, recruitment of counselors, or outreach programs, and also age-appropriate pace and content. So the information which they want to give is you can't have them, you can't ask them to sit there and you'll have a long list of explanation of why. So we will go very subtle, maybe about 5 minutes, 10 minutes, explain to them about, what are the risk factors and all that. Subsequent to that, we will say that, like example, sometimes we show some pictures, say that, this is what's happening in your brain, this is what has happened. So they are able to accept it. So, but because our outreach is not there, so mostly we use the family members as part of the team. Okay, so on average, like benzo reduction, so I write a contract with them. So normally a benzo regime reduction will be every month. I will drop by maybe about equivalent, if you are talking about with the Valium, so about 2.5 drop every month. So sometimes if they are on 10 milligram, 15 milligram, it takes about at least 4 months to 6 months. Sometimes longer because they'll come back and say that, doctor, when you drop further, maybe from, say, I brought him down to 5 milligram and he says that I can't tolerate anymore, I will give more time. Maybe I'll give another 3 months before I do the next drop. So there is no endpoint. Endpoint is abstinence, which is the best, but sometimes because they've been on this medication long term, it'll be very difficult. As regarding the opioid management, so we do not prescribe opioid, but opioid is prescribed by either the pain management team or palliative team or some other physician or surgeons are prescribing the pain medication. So we will liaise with them and will suggest what can be done. So if they decided for detox, then we will admit to the ward and we do the multidisciplinary team kind of detox. All right, so this is my last slide. Thank you.
Thank you, Dr. Param. Can I call you Dr. Param?
Yes, yes,
That's okay.
Yeah.
Is there any question for Dr. Param from the floor or from our online audience? The question chat is open. Please feel free to post some questions. There is. Okay, there you go. Thank you.
Good evening, Dr. Param. I'm Haslinda. I would like to ask regarding methadone maintenance therapy.
In elderly?
So due to demographic changes, so we are expecting more MMT patients are getting older. So are there any guidelines for MMT for older adults? And if there's none, is there any particular advice regarding MMT in older adults?
Okay. Yes, a very, very tough question. Okay. A bit of background of methadone. Okay, see, for older adults, normally if let's say the person is opioid dependent on MMT program, as long as you monitor the liver and all that, even if he's 60 years, 70 years old, is still taking methadone, it's not an issue. It's not an issue. But then you have to understand the testosterone level will go down, the prolactin level will go down, osteoporosis, risk of osteoporosis is there. So that kind of thing which you have to monitor. But the problem which we face now is they are not heroin dependent on a methadone program. These are people who are given painkillers like tramadol or oxycontin, oxycontin kind of thing. And over a period of 2 to 3 years, they've been on it. Now they're suggesting whether to put them on methadone. So this becomes a problem because methadone is not a good painkiller. The analgesic effect only lasts about 8 hours. So it is not a good painkiller and it is not a pure opioid. It is a bit of an atypical opioid. It doesn't work only on mu receptors, it also works in other receptors. So this is a bit tricky. So for elderly, if can, I would go with a minimum amount of opioids, whatever they take, like oxycodone, oxycontin. I will cut down to something which is manageable. If can, I would take him out from that using some symptomatic management and things like that. But I would not suggest a long-term methadone maintenance for a person who has some pain issues and he is dependent on oxycodone, oxycontin. One of the reasons why is elderly people, they do take multiple drugs. And methadone is a drug which interacts with most of the things. It interacts with the antidepressant, interacts with the antibiotic, you name it, one long list of it. So it will be very tricky to manage because once it's on methadone, you want to take out, you can't. When the physician or the other specialist want to add on other medication, there will be a direct interaction. So I would not recommend that. Buprenorphine is much better. It's based on temgesic. But again, the chances of abuse is there, so monitoring need to be done because that lasts for 72 hours. This time it's similar to the patch. So I would suggest that, maybe you go for the patch and then subsequently wean off from the patch would be better. I hope that answers the question.
So I guess I was part of the team who started methadone in 2005 because we didn't have any other option at that time. But I guess you are coming from the klinik kesihatan component. I think this is where the problem lies because they have people on treatment for such a long time, and by the time they refer to your department, it takes another longer time. I think maybe, when you spoke about the multidisciplinary team, I think this is where, we are seeing now a lot of our patients from, those time now transitioning into aging. So I understand where you're coming from. And I also understand your complexity as well.
No, if you are talking about methadone patients who are already on methadone, opiate people who are on methadone, that one is okay. That one you can actually wean off. You can taper off the methadone. Normally what I will do is, I'll ask few questions. First of all, I ask them, for the past 6 months or 1 year, have you been clean? You have enough family support, your work is stable, financially you are stable. So all that I will ask them. So if he says everything is okay, then I will say that, okay, are you ready to stop the methadone? So I will say that I will do gradual reduction, about 2.5 or 5 milligram reduction every 2 weeks or 4 weeks. But one important thing I will discuss is, okay, what about sober living? What about after the methadone? Do you think you can live without methadone? That means last time anything happens, you have methadone to support, or you used to take drugs and all that. Now methadone is holding you. Will you be able? So I will ask about that. The second thing I'll ask about that is, I'll tell them that, once they stop methadone, they become a bit irritable. They'll say they have sleep problem. Yeah. I said, this is a normal process. If you give some time, all this will go away. So then I'll do a gradual reduction. Sometimes I do auto reduction. I'll just tell that, okay, every month 2.5 reduction. Agreed? Okay, so I see you in 3 months time. Then the pharmacy will reduce by 2.5. So as they are reducing and they want to come out of methadone, sometimes when you are 5 milligram and all that, they find it difficult. So I'll add on some symptomatic medication for them for a week or two, because methadone can last even up to like 10 days, the withdrawal, as compared to heroin. It lasts maybe about 5 days. So therefore, I put on symptomatic medication. Even I do use some benzodiazepine at that time, just to help him to sleep, reduce the irritability. Put him on, for pain, body ache, usually I give Constant, and if you have diarrhea, whatever, symptomatic medication. So 1 week, 10 days. After that, I will ask the first question. So you have stopped completely? Okay, I have an option for him. So usually I put him on naltrexone. Naltrexone is an opioid antagonist. So that helps him to prevent him from taking any drugs, especially opioid based. So therefore, if someone is there supervised, I'll discuss with the family, the wife and things like that. So you put them on it. So it will help them to, even if he takes methadone, if he even takes heroin, there won't be any effect. So that gives you a cooling period for maybe about 2 to 3 months. After that, I'll off it. So that will be a good option. So methadone, they can go out. It's not an issue. Just that the pain issues, when they want to start on methadone, that's when the problem, because they are already on a lot of medication. There's a lot of drug interaction. It will be quite difficult, will be quite complex.
Therefore, the referral system is
Yes.
very, very important for you to work on, especially when it comes to transitioning people to an elderly scope. Thank you for that question, very relevant. Any other questions from the floor? No. Okay. All right. I have a question though. We know that, with COVID also, and prior to COVID, we knew there is this silent epidemic that is heading our way, which is mental health. And, you rightfully just, shown in your own slides that there's not much data on, we know dependent, we know those people who are dependent, we know where the data is coming from. But what about the silent epidemic? Prescription drugs, I think I'm sure with your experience, you would know this better than me. It's a huge problem, isn't it? So how could we do better? I mean, how we hear the 80% of the population, our delegates are doctors, and you have mentioned right ways of, exploring that when they see patients. But what about preventive measures that we can take in the community itself? Well, what can we do in aspect of capturing that information?
Okay, that's another tough question. It is difficult to define. For example, let's say if we take America for that sake. So their prescription, their opioid, like heroin use is much less, and it's replaced by all this prescription drug, one long list of prescription drug. And most of their drug users now, 40% of them are on prescription drugs. So it can be anything. They just take whatever they can get, whether it is a benzodiazepine, whether it is a stimulant, they perhaps like antidepressant. They'll just say, I feel depressed, I need to pop in 2 tablets of antidepressant. So that kind of thing. So prescriptions have gone up. But in Malaysia, unfortunately, we have certain issues. One is the prescriber. Whoever prescribes, if they can take responsibility for their script, I think it should solve 50% of the problem. That means you prescribe benzodiazepine, but you explain to the patient, this one, if you take, the risk of dependence and things like that. So, and you monitor. So that will settle 50%. The other 50%, unfortunately, they can go out and buy. Most of my patients, I don't know how they get it. They say that, they'll say certain doctors are selling, they say certain pharmacies are selling, they can get from outside, they can order from internet. So this one is a very challenging, I don't know how to stop this. But hopefully with certain laws or whatever, maybe they can stop. In other countries, what they do is, the easiest is, because when they have this insurance, everyone needs health insurance. So once you have health insurance, what they do is they bar you from getting the drug. The drug can be obtained only from one doctor. Like when I was in Australia, it was so easy. For the whole state, only you can prescribe this drug. No one else can prescribe. So it becomes very easy. So he cannot go over the counter, cannot go do a doctor shopping. So that's advantage. So hopefully one day our system is at that level. So hopefully we do not have this multiple script. Even the hospital, sometimes he comes to the psychiatry, asks for a sleeping tablet. He goes to orthopedic, asks for a sleeping tablet. Even us, he plays around. Doctor, 1 week supply is good enough, doctor. Yes. But
That's
hopefully
so
things changes, right?
All right. Okay. We are almost there now. Can we please thank Dr. Param for such an interesting talk?
Thank you.
Thank you.